ショートでいいんですか？
どうせ名前言うだけやね。
まあまあそうです。
Hey, how are you? Kevin. Nice to meet you. Sloan.
多分初めて。
あ、もう大丈夫です。Hello, everyone. It's after 11 o'clock, and I would like to start. I'm Naoko Takebe from Stevenson Cancer Center, Oklahoma University. I'm honored to co-chair this session with Dr. Masafumi Nakamura from Kyushu University and Dr. Ippei Matsumoto from Kinda University. Thank you for joining this session. And then we have actually 5 speakers. I would like to start introducing Dr. Kevin Suarez, the first speaker. Dr. Kevin Suarez is assistant attending surgeon and surgical oncologist at Memorial Sloan Kettering Cancer Center. And he earned his medical degree at the University of Massachusetts Medical School, completed his residencies, general surgery at the Johns Hopkins, and a further surgical training at the hepatopancreatic biliary and a complex general surgery at the Memorial Sloan Kettering Cancer Center.
Thank you. Thank you for that kind introduction and the opportunity to be here, and appreciate that from the organizing committee. So I'll be talking about mRNA-based neoantigen vaccines in pancreas cancer. I have no disclosures. So this is a large reason why we're all here today, is because obviously we have a lot of work to do, and this is one such example. This is the experience of pancreatic cancer treatment in the Dutch Pancreatic Cancer Registry from 1997 to 2016. Now, as you can see here, there's a statistically significant improvement in overall survival during this time. But realistically, you would look at this, it goes from 3.1 months to 3.8 months, and this is really clinically insignificant. And more importantly, where we see the tail of the curves goes, has not changed over the years. We still remain with very few long-term survivors. And the reality is that new agents are sorely needed. And with the excitement of immunotherapy in the last 20, 30 years, that really hasn't pertained to pancreatic cancer. And in part, this is in fact due to the fact that it's not really responsive to single agent immune checkpoint blockade through a variety of non-immunogenic mechanisms. It's got very few infiltrating T cells at baseline. It has very low checkpoint expression at baseline and a very low tumor mutational burden. But part of the reason we may not be seeing the progress we expect with immunotherapy in this disease may be the way we've been studying it, which in general has been in the metastatic patient population. And this is very different than the localized patient population. In the metastatic patient population, there's different immune suppression mechanisms. There's loss of class 1 HLA expression in 43% of tumors. The tumor microenvironments are significantly different in the metastases and the primaries. And very importantly, as we try to use novel agents and combinatorial therapies, studies in the metastatic setting really preclude great tissue specimens that can better understand immune response, immune resistance, and thus better educate us on how to combine immunotherapies, which are working, which are not. So localized pancreatic cancer, unfortunately, is a minority of the patients, but still about 20% of all pancreatic cancer patients. And this is really where we've seen the improvement in overall survival over the years. The reality is, however, that the majority will recur within the first 2 years of surgery, but this is a highly motivated subset patient population where we really have a realistic chance at getting long-term cures. So my colleague and partner, surgeon scientist Vinod Balachandran, started looking at this patient population with a very simple question. We have a number of patients who do really well after upfront surgery for pancreatic cancer and standard of care treatment and survive a long time. We have a subset of patients that recur shortly after their upfront surgery and their chemotherapy. And so he took these 2 cohorts and had a long-term cohort from Memorial Sloan Kettering with a median overall survival of 6 years, comparing with the short-term survival cohort, which had a median overall survival of less than a year. And right off the bat, you can see that when you look at these primary tumors, again, these are untreated patients who went to upfront resection. They had baseline statistically significant increased presence of CD3, CD8 T cells, as well as a baseline increased presence of CD3, CD8 positive, granzyme B positive T cells within the tumor microenvironments of these long-term survivors. So this suggests that perhaps there's some endogenous immune response that plays a role in the ability of these patients to survive the long term with standard of care therapies. And one of the main obstacles to pancreatic cancer has long been thought there are no targets. There are no neoantigens that we can use and generate an anti-tumor induced vaccine response. But in looking at these 58 tumors, we can see that on average, there are in fact approximately 38 neoantigens in these primary tumors that were resected. And so in addition to looking at their presence, we looked at the quality of the neoantigens. Quality being those that were most like infectious-derived epitopes, thus more likely to induce an anti-tumor immune response. And indeed, when you look at patients who had high-quality neoantigens versus those that had low-quality neoantigens, and this was done both from Memorial Sloan Kettering patient population as well as a separate cohort through the International Cancer Genome Consortium, we could see that having the presence of high-quality neoantigens was prognostic for improved overall survival. And so this generated the hypothesis then, can individualized mRNA neoantigen vaccines expand neoantigen-specific T cells and thus delay recurrence? And the first step to studying this hypothesis was to understand whether we could feasibly create vaccines after a major pancreatic resection and being able to administer these safely and assess the feasibility. So to do this, we conducted an investigator-initiated trial. This was targeting 20 patients who had upfront resectable pancreatic cancer, so no borderline disease, no locally advanced disease, and no prior therapies. And the study called for patients to go to surgery, at which point their tumor was resected and immediately shipped overseas to our industry collaborators where it was sequenced, both for tumor and normal DNA and tumor RNA. And from that, the neoantigens were computationally ranked and predicted. And these then were implemented into a custom manufactured individualized mRNA vaccine, which could contain up to 20 MHC1 and MHC2 neoantigens. So while their vaccines were being created overseas, the patients were recovering in New York, and at about week 6 postoperatively, they had their first dose of atezolizumab. And this was followed by 8 priming doses of vaccine and starting their standard of care chemotherapy for the 6-month period, and finally with a booster dose of vaccine at week 46. The primary endpoint was safety, and then as well as feasibility, but also secondary and exploratory endpoints looking at recurrence-free survival and immunogenicity. So the trial was started in 2019, and as many of you know, COVID hit, disrupted global supply chains, which for this trial was an important component of how to conduct it, but in the end, able to complete it about a year ahead of schedule. And with regards to the primary endpoint, both the atezolizumab and the vaccine were well tolerated with no grade 3 adverse events, and it appeared feasible. We could get both the atezolizumab and the vaccine to patients within 1 week of benchmark times, even after major pancreatic resections. So we then looked at the immunogenicity and used 2 independent analyses to understand vaccine-induced immune response. The first of which was interferon gamma ELISpot, and identified of the 16 vaccinated patients on trial, 8 were responders, 8 were non-responders, and of those 8 responders, 4 were polytopic responders and 4 were monotopic responders. This was corroborated in a clone track analysis, which is essentially looking at T cell clonal expansion with TCRV beta sequencing. And again, identified the same 8 responders, 8 non-responders, and additionally could see that these responses could be substantial. They could reach up to 10% of all blood T cells and durable, even persisting at up to 2.5% of all blood T cells after completing systemic chemotherapy. And at about a median follow-up of 1.5 years at the time when this was published, we could see that the responders had a median recurrence-free survival that was not reached, compared to a median recurrence-free survival of 13.4 months in the non-responders, which is along the lines of what we classically see in this patient population with standard therapies, and thus vaccination responses seem to correlate with delayed pancreatic recurrence after upfront surgery. This is a patient of mine on study, presented with a resectable head of pancreas cancer, underwent a robotic Whipple, postoperatively completed atezolizumab vaccine, and was approximately halfway through the chemotherapy when the CA19-9 is noted by the black arrow and the blue line here on the bottom left graph spiked. And this prompted an MRI, which is in the middle panel here. And in comparison to the preoperative MRI of the liver, we could see a new liver lesion that looked highly suspicious for metastasis. A biopsy was performed, and really what we saw was 1, no evidence of adenocarcinoma, but 2, a dense lymphoid infiltrate of both of CD8 T cells on H&E and immunofluorescence. Additionally, through clone track, we could see that this specimen contained all 15 of the patient's known vaccine expanded T cells. And through digital droplet PCR, we could see that there was rare cells there harboring an R175H mutation that was the same driver mutation from the patient's primary tumor. So given the absence of any metastatic adenocarcinoma on the biopsy, the patient continued with the systemic chemotherapy, and repeat MRI of the liver now demonstrated resolution of this lesion. and thus implicating that these vaccine-expanded T cells can infiltrate and potentially eradicate a micrometastasis, and this patient remains disease-free now 3 years post-resection. So since that publication, we now have more longitudinal samples as these patients have progressed over time, and this is work really being spearheaded by two very talented postdoctoral fellows in the Balachandran Laboratory, Zach Sepna and Pablo Gosp. And basically, we've been able to take peripheral blood samples as well as looking at the primary tumors and evaluate, can these vaccine-induced T cells persist long-term? Are they durable? And this is first looking at their estimated T cell clone lifespan in the top right corner here after both priming doses and boosting doses of vaccine. And the priming doses of vaccine seem to have a median lifespan of approximately 1 year, but with a single boost dose of vaccine, their estimated lifespan is now a median of 6 years, with 20% of these T cell clones having an estimated lifespan of greater than 10 years. And more importantly, as you look through where the recurrence window tends to be in this patient population, which is in the first 2 years after surgery, we see that the vast majority of patients who were responders had T cell clones that outlived this recurrence window. And so now we have longer follow-up with more mature data to reevaluate the association of recurrence-free survival and vaccine response, and that association continues to hold. The median recurrence-free survival in the responders not reached with a median follow-up of about 3 years in the responders versus a median recurrence-free survival of 13 months in the non-responders. But there are here 2 responders who recurred. And so we looked specifically at these 2 responders to look at their T cell dynamics. And ultimately, what you can see is one responder that did recur had essentially the lowest estimated lifespan of their T cell clones after vaccination. The other responder had the latest onset of their vaccine-induced T cell response. And this was actually because of COVID. This patient ended up having to have chemotherapy and getting vaccinated later on because there was no availability of the vaccine at the time. So overall, both patients who were responders and recurred had the lowest percentage of their blood T cells being vaccine-induced T cell responders, suggesting that this short duration or latest onset may have implications for recurrence in these patients. So there is a global study ongoing now, termed IM code 003, really now asking the question, is this efficacious? And so these are patients who have resectable head of pancreas adenocarcinoma, no prior therapies, no borderline or locally advanced disease, go on to upfront surgery, and then a randomized 1-to-1 to either vaccine, atezolizumab and FOLFIRINOX versus FOLFIRINOX alone, with a primary endpoint of disease-free survival. So in conclusion, obviously we need to do better in this disease, and novel agents are really the key to doing that. Immune responses after vaccine against tumor, pancreas cancer specifically, appear feasible and correlate with improved clinical outcomes. And likely immunotherapy clinical trial design for this patient population in a localized setting is going to be key moving forward. This is a tremendous amount of work from a large group of people, but first would like to thank our patients participating in the trials, the Sloan Kettering Hepatobiliary Tumor Board, as well as the Balachandran Laboratory performed a lot of this work. Thank you.
Thank you, Dr. Zores. We are going to take all the questions at the end. So we would like to move on to the next speaker. I would like to actually correct, I misspoke. There are 5 speakers today. The next speaker is Dr. Richard Tully from University of Southern Florida. Dr. Tully is a deputy director of the Tampa General Hospital and the director of the radiation oncology at Tampa General Hospital, professor and chair of the radiation oncology at the University of Southern Florida Health Mersani College of Medicine, and his title of the talk is a radiation therapy clinical trial.
Thank you. Good morning, everybody. Thank you to the organizers for the opportunity to talk to you today on the landscape of radiotherapy in localized pancreatic cancer. So this is a slide that I've used for many years. It's an oldie but a goodie. I think it's It's an old slide, but I think it highlights very effectively the uh, prognostic significance of microscopic disease and pancreatic cancer. This is a series of several single institution studies that I think highlight two important points. The first, that the percentage of patients who have microscopic residual disease post upfront resection was significant, remains significant, and the prognostic significance of an R1 resection, as you can see here, leads to an almost 50% reduction in the median overall survival of these patients, whereas these numbers have improved over the years with the advent of better systemic therapies. It certainly remains a significant problem. This was well characterized, I think, in another seminal study by Chris Acabuzio when she was at Hopkins. This is a small but significant study looking at approximately 80 patients who underwent autopsy as a result of death from pancreatic cancer. And whereas the vast majority of patients, more than 80%, were identified to have metastatic disease at time of autopsy, more than 1/3 died from locally advanced and locally destructive disease. So I think this highlights a twofold problem. The first is that in the neoadjuvant adjuvant setting, the prevention of incurable isolated recurrence remains a significant problem. Additionally, in patients with unresectable and in the definitive setting, the prevention of, I'll also call incurable local progression is something that needs to be appropriately dealt with in order to improve clinical outcomes as well as the associated morbidity and mortality. So, this is a slide of SBAC4, which is a more contemporary study looking at patients who underwent upfront resection, followed by randomization to gemcitabine versus gemcitabine Xeloda. And I put this slide up to highlight that these patients did not receive radiotherapy as any part of their treatment. Post-surgery, 60% of patients were found to have margin-positive disease defined as tumor at ink. With local regional rates that were as high as 50%, and not surprisingly, positive margin predicted for worse overall survival with a hazard ratio approximating 1.3. I think this is the flip side of the coin. This is a study by Bill Regine that was published some years ago. It was a phase 3 randomized trial run through the RTRG that also took patients with resected head of pancreas adenocarcinoma and randomized to 2 adjuvant regimens, a radiation gemcitabine sandwich and a radiation 5-FU sandwich. In this study, the positive margin status was not an independent predictor of survival, nor was it a predictor of local regional recurrence, which occurred in 30% of patients. So I think we see, the data is slightly different when we're incorporating radiation into the adjuvant setting, and really begs the question as to what is the role of radiotherapy for local regional disease control. As a result of these data, we published our consensus guidelines just a few years ago, and you can see that the strength of recommendation is conditional given the low quality of evidence, and that is specific to the role of radiotherapy in the adjuvant setting after surgical resection. However, there is a consensus recommendation for the use of radiation in the postoperative setting for patients with both positive lymph nodes or margin positivity. So what are some strategies that we're using to try to overcome these problems? One is very simply a dosing strategy in radiotherapy, and that compares conventional dosing, which is a component of the studies that I've presented already, versus the emerging data regarding stereotactic body radiotherapy known as SBRT or stereotactic ablative body radiotherapy or SABR. And one important component here is that we should have the capacity to be able to compare dosing regimens. And we do this using something called a biologic effective dose or BED, which allows us to compare the biological effects of different radiation therapy regimens on tumor and normal tissue. So simply put, bigger fraction sizes are more potent. 4 gray in 1 fraction is more potent than 4 gray delivered in 2 fractions. And typical BEDs, as I will reference in the remainder of the talk, would be in the form of conventional radiation achieving a BED of 45 to 50 gray, which I'll reference as low dose, or a BED of stereotactic radiotherapy greater than 70 gray and upwards of 100 gray, which we'll reference as high dose, which can be given in either 5, 10, or 15 fractions. So again, just to set the stage, these are some seminal studies, randomized studies looking at the role of radiotherapy in locally advanced disease, comparing chemotherapy to chemoradiotherapy regimens. And we can see that the majority of all studies are negative in terms of any potential added benefit of radiation. I'll focus in on the LAPO-7 study, which was probably the largest, of those referenced here, where there was no difference in PFS or overall survival, which was a primary endpoint. However, chemoradiotherapy significantly decreased rates of local progression and also delayed the time to next treatment. So there was somewhat of a signal when you dig into the details. This is a similar contemporary study, CONCO 007, which studied patients with locally advanced pancreas cancer who underwent upfront chemotherapy followed by randomization to standard low-dose chemoradiotherapy versus continued chemotherapy. Again, no difference in median PFS, OS, significantly higher grade 3 toxicities with chemoradiotherapy, but interestingly higher pathologic complete response rates in the CRT arm, as well as R0 CRM rates. So this sort of provided the impetus to really look at the potential benefit of higher doses of radiation. Some of the earliest studies were published by Sunil Krishnan and the MD Anderson experience. This was a retrospective study in patients with locally advanced pancreas cancer who received chemotherapy followed by radiotherapy. And these patients are stratified based on a BED greater than 70 versus less than 70 based on various dosing regimens. And what you see is that there is almost a doubling of the 2-year overall survival with the higher radiation doses. Similarly, a multi-institutional study, also retrospective, looked more concretely at patients who received approximately 100 gray BED versus those who received 50 gray BED chemoradiotherapy, again, after upfront chemotherapy. And you can see here also a substantial increase in the 2-year overall survival with the use of high-dose radiation. This is probably the largest series to date that we completed at Sloan Kettering. This is also a retrospective experience of about 120 patients who had received upfront systemic therapy followed by high-dose radiotherapy with a BED of 98 gray delivered in either 15 or 25 fractions, concurrent with radiosensitizing chemotherapy, with a 2-year overall survival of 40%, freedom from local progression of 30%, and importantly, very low toxicities in the acute and subacute setting. Other potential strategies include the use of dose modifiers in this setting, either with conventional low dose or high dose radiation. I'll focus in on a couple of studies that have looked at some of these strategies. This is a phase 1 study that we published a few years ago, looking at patients with locally advanced pancreas cancer, treatment naive, who received a combination of low-dose radiotherapy in combination with full-dose gemcitabine at 1,000 milligrams per meter squared and dose-escalated veliparib, which is a PARP inhibitor. This was a well-tolerated regimen. Again, these patients were treatment naive, did not receive upfront systemic therapy. We can see a median progression-free survival approximating 10 months with a median overall survival of a not too impressive 15 months. However, when these 30 patients were stratified based on transcriptomic analysis, looking at expression of nucleotide excision repair markers, as well as mismatch repair markers, you can see a significant difference in terms of how those curves separate for the benefit to those patients who were deficient in expression. Another study along the same vein was published by Kyle Cuneo and Ted Lawrence out of the University of Michigan. And this was also a phase 1 study in patients with treatment-naive locally advanced pancreas cancer. Herein they combined radiotherapy at standard dose with full dose gemcitabine and a WEE1 inhibitor, adavosertib, which is a drug that abrogates the G2 checkpoint, induces replication stress, and inhibits homologous recombination, so similar to PARP inhibition. These patients received induction chemotherapy followed by, for a couple of weeks, followed by treatment with the drug, chemo, and radiation, and consolidative chemotherapy. And what they saw was a very impressive median overall survival of 22 months with an upfront radiation strategy. This is a study that's currently nearing conclusion. This is one that was completed between Cedars-Sinai and Sloan Kettering, a phase 1/2 study in patients with locally advanced pancreas cancer who had received upfront chemotherapy without progression of disease, with subsequent treatment, including durvalumab, the PD-L1 inhibitor, followed by high-dose stereotactic radiotherapy with BEDs of 100 gray, and then maintenance durvalumab until progression. In this study, we saw median overall survivals approximating 17, 18 months. This was post-chemotherapy. And in the swimmer's plot, we see some durable responses with patients who continue to progress without evidence of disease. We continue to conduct immune correlatives. These are being done by Josh Schoenfeld up at Sloan Kettering. And preliminary results indicate baseline increases in resident intratumoral CD3 positive, CD8 positive T cells, as well as CD3, CD4 positive FOXP3 cells are do predict for improved clinical outcomes. I think I'm over time for the sake of time. So we recently published a consensus atlas recognizing the complexities associated with the use of dose escalated radiotherapy to help the community at large with this treatment, which is now becoming more and more prevalent. And it's quite timely as it is in support of a new trial that will be opening hopefully in early 2025, which is the NRG GI011 or LAP 100 study, which should help us address confidently the role of dose escalated radiotherapy, at least in the locally advanced pancreas setting. These are patients who could have received Gemabraxane or modified FOLFIRINOX for 3 to 6 months. In the absence of progression, patients would be randomized to dealer's choice standard of care, which would entail either chemotherapy or standard dose chemoradiotherapy or observation, or dose escalated radiotherapy utilizing the various regimens below. So with that, I thank you for your attention.
Thank you very much, Dr. Tully.
I'd like to introduce the next speaker. Next speaker is Dr. Rajek from University of Texas. Dr. Rajek is Executive Director of Mays Cancer Center, University of Texas, Health San Antonio Emily Anderson Cancer Center, and Vice President for Oncology and Professor of Medicine at the University of Texas Health Science Center at San Antonio.
Thank you so much for introduction. So, I was still asked to actually talk my experience at Johns Hopkins, and many of my experience share with the speaker here, Dr. Soares and Dr. Tully, is also my prior colleagues at Johns Hopkins. So I have some disclosure. So when I started my faculty at Johns Hopkins, one of the question actually is I'm struggle with is that pancreatic cancer has a cold microenvironment, And as you can compare with the, in the multiplex immunohistochemistry, on the left panel is the pancreatic cancer, compared to the right panel, which is the microcystin stable high cancer, pancreatic cancer, lacks T cell or high quality T cells. So the hypothesis we raise is, can we use the vaccine turn the pancreatic cancer tumor microenvironment? And the time matrix, my mentor, Lee Jaffe, has developed this allogeneic pancreatic cancer whole cell vaccine, which is transfected by the plasmid to express GM-CSL. If off-shelf produced at Johns Hopkins GMP and has excellent safety, it can induce robust peripheral T cell response, and but have a limited efficacies. So then we use this vaccine as a tool to prime the tumor microenvironment. We have the hypothesis to test whether the vaccine can turn this tumor microenvironment on, and what is the role of the anti-PD-1 antibody. At the time, it was just actually is FDA approved for treating many of the hot tumors, as you know, actually like melanoma, lung cancer. So together with my surgery colleague and some actually sitting in the audience, some is sitting on the here, and we developed these platform trials and to compare the vaccine and the vaccine plus nivolumab, and given 2 weeks prior to the surgery, and followed by the surgery and standard of care chemotherapy, as well as the maintenance chemotherapy. So we also collaborate with Lisa Cousins group has developed this sequential staining stripping multiplex in the histochemistry to analyze the what we observe in the prior study that vaccine can induce the tertiary lymphoagate. So allow us actually to analyze the lymphoagate on the same slide section by using multiple immune marker, including a T cell panel and also myeloid cell panels. So this is example by overlay assigned with each marker with a pseudo color or overlay, we are able to actually quantify the different cell types on the same slide session, particular for the same lymphoagates. So we do see at least the effect of anti-PD-1 therapy decrease the PD-1 positive T cell, including the CD8 positive T cell and CD4 T cell positive, and this decrease of the CD8 positive and the PD-1 positive and CD4 positive, PD-1 positive correlate with the patient's survival after the neoadjuvant immunotherapy and the surgery. However, for what we call the high quality granzyme B positive effector cytotoxic effector T cell, they don't correlate with the survival. Their absolute number also very scarce in the tumors. So that's why missing something. But then we find that the higher density of the CD137 positive, CD8 positive, which is active T cell. CD137, now named 4-1BB, is a T cell co-stimulating factors represent the activation status of T cell. These subtype of T cell following the GVAX and nivolumab treatment associated with a higher density of the granzyme B positive, CD8 positive T cell. That we raised the hypothesis we need to increase activation of the T cell. So how we do this? So the CD137, there's an agonist antibody. So we first test the mouse version, the surrogate of the CD137 agonist antibody in our mouse model. And and the same mouse model is the hemispring mouse model, which is developed together with Dr. Soares, actually, so we learned from Dr. Schulich's laboratory. So we implant this tumor as a liver metastasis and treat it with the triple combination of CD137 agonist and the anti-PD-1 blockade antibody, as well as the GVAX, mouse version of GVAX. We find that it can significantly prolong the mouse survival. And this effect depends on the GVAX. So then we think we need a target of both inhibitory and co-stimulatory signals. Inhibitory signals is represented by the anti-PD-1 treatment, and the co-stimulatory signal by targeting the CD136 antibodies. So at the time, BMS has developed these fully human anti-CD137 agonist antibody. It has some toxicity issues, so that's why we use the flat dose. But even the flat doses show actually have a T cell activation activity. So we developed, further developed this platform trial by adding the third arm, which is a triple therapy of the GVAX and the nivolumab and the urelumab is the CD137 agonist antibody with a flat dose, and the design is same. So we keep it as a platform trial. So we keep adding the new arms. So this new arm is also given 2 weeks prior to surgery, allows to analyze the tumor reset from the surgery. So first we look at the clinical efficacy. Unfortunately, BMS only give us the doses for 10 patients because they stopped the clinical development. I'll come up with why they stopped the clinical development. But even just the 10 patients, we find that 3 out of 10 patients had a pathologic response only after 1 treatment of the triple combination. And then as a result, we also seeing actually improved disease-free survival following the surgery. So it's not statistically significant, but it's really actually it's very significant clinical improvement. So we further down the single cell analysis of the resect tumor. That's the beauty of this platform trial, allow you having a big tumor for analyze the tumor microenvironment at the spatial level by multidisciplinary immunohistochemistry and also at a single cell level. So we did a single cell transcriptomic and also the TCR analysis. Combine them together, we find that the T cell clonality was expanded after the PD-1 treatment, particularly after the triple combination with the anti-CD137 agonist and the PD-1 antibody showing this graph here. And we also find that the T cell activity signal based on the whole transcriptomic analysis also enhanced. So how we do next? So then, I think Dr. Soros actually is also provide us some clue. They have one version of the KRAS vaccine. So we also have at Hopkins, Lee Jeffries group developed this also long peptide pooled actually is KRAS vaccine. So the patient will receive this pooled KRAS mutated KRAS vaccine regardless their KRAS mutation status. The first clinical trial, the patient has received this vaccine after the surgery. And the patient also received ipilimumab, anti-CD4 antibody, and also the anti-PD-1 antibody, the nivolumab. So based on the analysis of peripheral T cell analysis, almost every patient you see at this induction of the T cell to a certain mutated KRAS. This is consistent with the tumor's intrinsic KRAS mutation, but also you can see at least the induction of the T cell in the non-intrinsic address KRAS mutation. That suggests there might be epitope spreading, or in general, there's a T cell priming effect. And the induction of the KRAS, mutated KRAS specific T cell response correlate with the patient's disease-free survival. And also we find the vaccine induced the mutated KRAS specific TCR can recognize more than one KRAS new engine, as show this using this case example. As you can see, on other cases also have the response to the TCR response to the mutated KRAS from this patient, just to a different level in other patients. So that suggests there's an induction of mutated KRAS space TCR. So that's encouraged us that we can certainly aim at the new antigen, particularly this shared new antigen. But then we need a better actually CD137 agonist antibody. So more recently, there's second generation of anti-CD137 agonist antibody. This is one of the representative developed by the Agenus. And so this is an antibody actually is modified, engineered at their FC-dependent antibody cross-linking to reduce the potential toxicity. So the phase 1 actually dose escalation go up to 10 milligram per kilo actually is much better than the urelumab from the DMS. And then we also see actually two objective response, including one is an ampular cancer patient. Among these patients actually is in the phase 1 single agent studies. So this is a signal is very encouraging. So then based on that, we are designing our follow-up trials to have a 2-arm and both arm will receive the PD-1 antibody from the same company and also the anti-CD137 agonist antibody. But the vaccine will be different. So it's a GVAX, either GVAX or KRAS, mutated KRAS vaccine. So we want to see whether, GVAX and the mutated KRAS both can induce this tertiary lymphoaggregate. So we know actually the new antigen targeted vaccine can induce the high quality T cell, particularly from Dr. Soros' presentation. And but also seeing actually from Dr. Tully's presentation, there's a way actually also induce other actually the new antigen and T cell. For example, you give a radiation that potentially have in situ vaccination effect. So which way actually we approach? So I think we need actually identify actually the more T cell epitope, particular new epitope. Our current way actually is identify the new epitope is very limited based on the whole exome sequence. And Dr. Soros can tell how challenging is that to identify one new epitope. However, if you're using radiation, just as in situ vaccination, you're probably not able to actually induce a particular specific new epitope that you want. So we identify this new epitope by the immunoaffinity purification by using HLA complex and using this antibody affinity column that packed with the antibody with the pan HLA class 1 antibody and further go through the class 2 antibodies. So we're very successful as you see the epitope enriched at the 9-mer. And we also find actually that they're shared by multiple patients. As a matter of fact, if 132 peptide is shared by the 3 patients. So not only actually is class 1, class 2, and the class 1 can also share the same region as class 2. As a matter of fact, if the class 1 epitope and the class 2 epitope share the same region, same sequencing, and this epitope actually is very strong, can induce a polycytokine reaction as shown here. And so then the next step is first to prove the concepts. We want to develop the adoptive T cell therapy and more specific the T cell specific therapy. So we clone the TCR. Now the technology is so easy. We just do the minimal culture using this peptide to stimulate the T cells, and then we do the single cell TCR analysis, and we can actually clone the TCR. And and then we actually put this TCR in the retrovirus, and we not only clone the CD4, CD8 TCR, but also clone the CD4 TCR. And then we find if we use actually the CD4 TCR that recognize the same epitope as the CD8 TCR. And this CD4 actually is a TCR has a strong regulatory activity. They can enhance the anti-tumor activity of the CD8 epitope. Not only this in vitro experiment, but also in vivo. So in this in vivo experiment, we also actually infect the PBMC with this CD8 T cell TCR, and also infect the same number of the T cell with the CD4 TCR. And then we mix them together as shown in the lower panel, and they actually significantly enhanced the anti-tumor activity of the CD8 TCR T cell therapy. So, and then long story short, we also find that the T cell epitope has a mutation, single amino acid substitute. And this single amino acid substitute actually is in some of the epitope can enhance their T cell activation activity and also the MHC binding activity. So we still don't know it's a mechanism. So we call it non-canonical new epitopes. And they're not coming from a dark genome, but we believe they come from the translational error. We'll continue to actually sort out their mechanism. But we find this actually is a new epitope also shared by multiple patients, and they're cancer enriched. So we're actually using this epitope to develop actually the vaccine, particularly on the mRNA vaccine platform. So we don't need to bother actually doing the sequencing, but we just actually design this actually shared actually non-canonical epitope mRNA vaccine for all the patients. hopefully it's a work. Thank you very much for your attention. Okay, sorry to be over the time.
Thank you. I'd like to introduce the next speaker. Next speaker is Dr. Sohei Satoi. Dr. Sohei Satoi is the professor and the chairman, Department of Pancreatic Surgery, Kansai Medical University. He is a visiting professor at multiple institutes, Tokyo Medical University, University of Korat, University of Vilnius, and the Kingo University, China.
Yeah, thank you, Chairman. It's my great pleasure and honor to present my talk titled on can the functional food HCC improve survival in patients with pancreatic adenocarcinoma. So COI is shown in this slide. I have a COI with amino acid company which producing HCCs. So what is HCC? You know this one? So it is a standardized fermented extract of cultured mushroom mycelia. It comprises of polysaccharides, amino acids, and minerals. Has been proposed that to have a health benefit that are mediated by immunomodulatory and anti-tumor properties. It is designed to modulate the natural immune system in the body, and it has been developed in 1987 in Japan, and a manufacturing process is, as written below, is well organized and established, and it is only produced in Japan, and it was exposed to the other worlds. So it is also rich in the partially silated alpha-1 glucans. It has been used mostly in integrated medicine in terms of oncological field, and also has been used in more than 40 countries, including United States, over 30 years with accumulated scientific evidences, over 100 publications, including over 30 human clinical studies. So preclinical studies showed that HCC has immunomodulatory effect, such as anti-inflammatory effect, antioxidant effect, enhancement of resistance against the bacteria, such as MRSA and Klebsiella pneumonia, and viral infections such as COVID-19, and West Nile virus, and human papilloma virus. And anti-cancer effects, synergistic effects with the gemcitabine in pancreatic cancer cells, increase in the anti-tumor activity of cisplatin and a Muller model, along with the mitigating the side effects of the chemotherapy agent. So this study, it was shown by Smith et al. They conducted randomized double-blind placebo-controlled study using 41 patients with high risk of HPV. Group 1 was consisted of 22 patients with high risk of HPV who had a HCC intake of 3 grams per day for 6 months, relative to the control group of 19 patients who didn't have any HCC. So this study demonstrated that HCC is effective to clear persistent HPV infections. The suppression of INF beta level correlated with the clearance of HPV infections. So although it is very small study, now Hokkaido University group also conducted a randomized placebo-controlled study for evaluating the effect of HCC intake on eradication of high-risk type of human papilloma virus infections. So they compared the clinical effectiveness of HCC between the HCC group in 90 patients who had 3 grams per day for 12 months, and a placebo-control group in 19 patients. The primary endpoint was persistent infection of a high-risk HPV. So patient recruitment was already completed the last year, and the final results will be opened next month, hopefully. So it will be appeared very soon. So, and we have conducted the prospective cohort study to investigate the HCC clinical effectiveness for the patients with hepatocellular carcinoma who underwent hepatic resections. So HCC group was consisted of 113 patients who had HCC oral intake of 3 gram or 6 gram per day for 6 months relative to the control group who didn't have any HCC as an adjuvant setting. So HCC intake resulted in improved liver function and prevention of recurrence of HCC after resection and the prolonged survival of post-operative HCC patients without any adverse events. So therefore, HCC treatment is a variable adjuvant therapy as a biological response modifier in these patients. So ASCO post 2022 featured the HCC as an potential anti-cancer effects and the alleviation of the adverse effects associated with chemotherapy. So we have conducted several clinical studies, even in pancreatic ductal adenocarcinoma. This is a paper for investigating an alleviation of the effect of HCC on chemotherapy-related adverse events in patients with unresectable PDAC. So we have conducted prospective cohort study from 2007 to 9. At that time, gemcitabine was the standardized chemotherapy before introduction of FOLFIRINOX of GNP. So 75 patients with unresectable disease was recruited into this study. So you can see the albumin level, CRP level, and the modified GPS level was maintained in the HCC group relative to control group. So HCC may, maintain the nutritional and immunological functions during the chemotherapy. So, and also we have conducted a double-blind placebo-controlled randomized trial using 98 patients with a PDAC receiving gemcitabine from 2015 to 19. HCC group was consisted of 55 patients who had a 6 gram per day of HCC intake for 2 or 3 week month, and a control group in 43 patients. So this study endpoints for incidence of grade 2 or 3 anemia or taste disorders. So it is quite similar results as a previous retrospective study. Albumin level, transferrin level, CRP level, and modified GPS level was well maintained in the HCC group relative to control group. And also primary endpoint, although there was no significant difference in the incidence of anemia between two groups, but taste disorder was less frequently found in the HCC group relative to control group. So, and also we investigated the scoring of gustatory functions in 4 basic tastes, such as sweet, salty, sour, and bitter. But in the patients with a positive taste disorder, the salt sensor was lower than the patients with a negative taste disorder. So the HCC may, treat good response for the taste disorder. So, and also we investigated the nutritional impact of HCC for patients with the resectable, border unresectable PDAC treated with neoadjuvant therapy. It is a very small study and also single center retrospective study, but neutrophil lymphocyte ratio and a prognostic nutritional index was better in the HCC group after neoadjuvant chemotherapy. And also CA19 level after neoadjuvant chemotherapy was lower in the HCC group, and also relative dose intensity was higher in HCC group. So this study might suggest the HCC can make an improvement of overall survival through the maintenance of nutritional impact in patients, even in patients with resectable disease. So now we have conducted a multi-center double-blind randomized control trial of ACC for patients with resectable, borderline resectable pancreatic duct adenocarcinoma. So we compared over 2 years disease-free survival in patients with ACC group, which is comprised of 115 patients and placebo group. Primary endpoint was 2-year disease-free survival. So, and also we have conducted ancillary study for checking the change in the gut microbiota during neoadjuvant chemotherapy between 2 groups. So now we have completed 230 registrations for 2.5 years the last year. The next year we can complete followed up after the 2 years after the final registrations, and also we can take the results and we will report them. And also we also have conducted the multi-center phase 2 study of ACC to explore the improvement in treatment outcome in patients with unresectable PDAC. The recruiting patients were 130 patients who received neoadjuvant, nab-paclitaxel with gemcitabine as a first-line chemotherapy, followed by irinotecan plus 5-FU leucovorin as a second-line chemotherapy. So primary endpoint was 1 year overall survival. So now we already collected 116 patients enrolled in 89% of the total cohort. I'd like to thank our participating centers for recruiting many patients into these trials. So I cannot, make definite answers against the clinical question of can functional food ACC improve survival in patients with PDAC, but we expect that results of ACC improve survival in patients with PDAC through the high completion rate of neoadjuvant chemotherapy and adjuvant chemotherapy with maintenance of a nutritional function and alleviation of adverse events during chemotherapy. And also, we can expect ACC keep the gut microbiota during chemotherapy. Thank you very much indeed for your kind attention.
Thank you, Professor Sotoi.
Next speaker will be Dr. Atsushi Oba from Cancer Institute Hospital from Japan. He works as a chief physician of HPV surgery in his hospital. He's one of the most and upcoming HPV surgeon in Japan. The title of his talk is The Efficacy of Wrapping with Polyglycolic Acid Mesh and Fibrin Glue in Preventing Clinically Relevant Pancreatic Fistula After Minimum Invasive Distal Pancreatectomy Wrap Study, Multi-Center Randomized Control Trial. Please start your lecture.
Professor Matsumoto, thank you very much for a kind introduction. And I'd like to appreciate this great opportunity to share our ongoing project. Here we go. So this is my COI disclosure. And this is my brief introduction. So today we're going to talk about the pancreatic fistula after distal pancreatectomy, still clinically relevant, yes? Hiroshima in Japan team investigated reinforced stapler, the usefulness of reinforced stapler compared to the bare stapler. And the result looks nice, but not statistically significant, led by Professor Uemura. And this is my case. I did the distal pancreatectomy with reinforced stapler, and the patient went well. But unfortunately, POD9, she got the severe peritonitis due to the major fistula. And then our endoscopist nicely treated her with ENPD, and she recovered fully, thankfully. But this experience made me feel like something missing, something's need to prevent the pancreatic fistula intensively. So we searched, and Korean team led by Dr. Jin and Jan showed that the usefulness of PGA mesh, polyglycolic acid mesh wrapping reduced intensively the clinical relevant POPF during the open distal pancreatectomy. So in the era of MISDP, because robotic and laparoscopic DP is a very dominant, right? So there's a few evidence of a randomized control trial which show the best practice to prevent the pancreatic fistula. So we adopt first PZA wrapping with fibrin glue after stapler. And then the method is following. The patient underwent the DP with a reinforced stapler for pancreatic parenchyma, and the PZA mesh was underlaid below the pancreatic stem and wrapped around. And then followed by fibrin glue application on the wrap stem. So this is the video. First, underlay the stem with the first PZA mesh. So believe me, this is very convenient and easy, even though my fellows do this and taking only 3 minutes or 4 minutes. So applying the fibrin glue on the first PZA mesh and additional wrapping of the second PZA mesh. And applying the fibrin glue on wrap stamp. That's it. It's very easy. Then we checked our retrospective cohort. And although there is no statistically different, the amylase level are consistently tend to be lower in the PZA wrapping group. And the PZA wrapping group, the time required for drain removal and hospital stay were significantly shorter compared to the control group. So the rate of POPF in the PZA wrapping group was significantly lower than that of control group. And this is also important. Re-drainage or readmission are comparable. So PGMS was also independent protective factor against the clinical rebound POPF with age. So PZA mesh and the fibrin glue effectively reduced the incidence of POPF. But of course, this is the retrospective single center study. So needs multi-center randomized control trial to prove it. And also I'd like to take this opportunity to thank Dr. Delchero, Dr. Satoi, Dr. Shurik, Dr. Takaori for supporting me a lot. So this is our recent published paper study protocol. And so this is the RAP, we name it the RAP study. So same procedure. So we stratified the patient, 2 groups with PZA mesh and fibrin glue, without PZA mesh and fibrin glue. And randomization factors are center thickness. It's a threshold is a 40 millimeter based on the Hiroshima study, and age and malignancy. And thankfully, many big centers in Japan participate this study. And also Gunze Medical Corporation and Chain Biology Corporation founding this project. And we need 172 cases. The primary endpoint is incidence of a clinical relevant POPF. And so far, registration and recruitment are going well, very thankfully. And I sincerely appreciate all participant centers and doctors and friends and members. So coming to the conclusion, the RAP study will determine whether this reinforcement could become the best practice or not in the era of MISDP. Thank you very much for your attention.
Thank you very much. Only
So-
one question, please.
I'm Ming from Peking Uni. I have a question for Dr. Soros. Very great talk, encouraging data. I'm wondering, is it worth trying to replace the PD-L1 antibody with PD-1 antibody or CTLA-4 antibody? Basically, they are all T-cell based immunotherapy, but from the recent KRAS inhibitor clinical trial, it is amazing that the combination with CTLA-4 antibody has much better response than the PD-L1 antibody. Thank you.
Thank you. Thank you for that question. The role of PD-1 or checkpoint inhibitors with vaccine therapy actually remains to be determined, in my opinion, as to not only which checkpoint inhibitor, but the timing of the checkpoint inhibitor. So we're actively trying to investigate that through other clinical trial designs. What we see in the mRNA vaccine study with the checkpoint inhibitor in that phase 1 study I presented, basically the T cell response to the checkpoint inhibitor there is pre-existing T cell responses, which are short-lived, which is different from the vaccine, which are de novo primed T cells. So the newer study now, the ongoing global study actually has the checkpoint inhibitor implemented a little bit later on in the priming. And I do think that that's an area that we need to do some further investigation rather than, at this point, it's been random somewhat as to how it gets implemented with vaccines, and further study design can better inform us how to do this moving forward.
Hi, I'm Diksha Kapoor from India. My question is to Dr. Oba. That was a great talk, and looking forward to the results of the study. My question to you is, what was the criteria of drain removal on in both the arms? Because that will determine whether it was a grade B fistula or not.
Thank you, Diksha, as always, and great question. So drain removal, we have some kind of rule. So if it's not the mandatory, but the recommendation, if the drain amylase of so the level of amylase of the drain is lower than 5,000 IU per liter on day 1, we recommend to remove it at day 3. But otherwise, we can continuously keep it. But it's very leave it up to institutional decision, because we are very flexible, because otherwise we cannot do the surgical randomized control trial, right? So we are very open.
Thank you. It would be great to see that data.
Thank you very
Thanks.
much for
all
your
the
question.
best.
Okay, we had a very fruitful times with very interesting talks from 5 distinguished speakers. Thank you very much for participating in this session. I'd like to close this session. Thank you.